All right, diving in today. Upper GI stuff. Huge topic. Affects so many of us in different ways.
Absolutely.
And we've got quite a detailed presentation from a listener. Thanks for that, by the way.
Yeah, very thorough.
But we know you don't have all day to wade through every bit of it.
Right.
So our mission, as always, is to pull out the really useful stuff, give you a strong grasp of these conditions without it feeling like, a medical school lecture.
Exactly. We want to empower you, give you the knowledge you need to really understand what's going on.
That's it. So think of this as your express lane to upper GI knowledge. From appetite problems to, well, scarier things like cancers of the stomach and esophagus.
And everything in between.
So jumping right in, anorexia. Now, not the eating disorder, we're talking loss of appetite here.
Yeah, that's an important distinction.
But it can signal something else is up, right? What's actually happening in the body when this occurs?
Well, you're right. This kind of anorexia, it's not a psychological thing in this context, but it is a symptom. It just means a decreased desire to eat, and there's usually a reason for it. Often it's tied to an underlying illness of some sort.
Okay.
The thing is, our brains have this appetite center. It's in a part of the brain called the hypothalamus. That's where those hunger cues come from. But all kinds of things can mess with that center.
Like what?
Medications, for one, stress can do it, and then a whole bunch of different diseases.
Oh, wow.
It is interesting, though, how the body adapts. Short term, if you're not eating, your body's got this backup system called glycogenolysis. Basically, it breaks down stored glucose for energy.
So it's using those reserves.
Exactly. And hormones like glucagon, they kind of kickstart that process. Problem is, if this goes on for too long, well, that's when you run into malnutrition.
That makes sense.
Mm-hmm.
So if someone's dealing with this kind of anorexia, what are the red flags we might see?
Okay, well, obviously, no hunger. That's a big one. Often comes with nausea, too.
Yeah, it doesn't sound fun.
No, not at all. And then you start to see the physical effects of not getting enough nutrients. Doctors use this thing called BMI, body mass index. If it dips below 19, that's malnutrition territory.
Oh, okay.
And if it's really severe, goes on for too long, it can even mess with your heart's rhythm. We call those dysrhythmias.
So the impact goes way beyond just an empty stomach.
It really can.
And what about blood work? What would that tell us?
Blood tests can reveal a lot. Low hemoglobin, for example, and low overall blood cell counts. Those are signs you're missing key nutrients.
Interesting.
You also see low levels of albumin and total protein in the blood. Again, points to not enough nutritional intake.
Makes sense.
And then there's hypovitaminosis. That's just a fancy way of saying vitamin deficiencies.
Right.
It's important to remember your body doesn't hang on to those water-soluble vitamins for very long. Things like B vitamins and vitamin C. You need a steady supply.
So you got to keep topping those up.
You do. And then there's the fat-soluble vitamins, A, D, E, and K. Those need fat to be absorbed properly. So if someone's malnourished, they're not absorbing those well either.
Okay, that's pretty complex. So how do doctors and nurses approach this? How do they manage it?
Well, if it's a short-term thing, say a bug that's making you lose your appetite for a few days, you might not need any specific medical intervention. Your body can usually bounce back pretty well.
Okay.
But if it's lingering, then the focus shifts to making sure you're getting the nutrients you need, one way or another.
I see.
This might involve oral supplements, those drinks or powders that pack in extra calories and nutrients. And for more severe cases, you might need a feeding tube. Or even TPN, total parenteral nutrition.
What's that?
Basically, it bypasses the digestive system altogether. Nutrients go straight into the bloodstream.
Wow.
Yeah. And if it turns out to be anorexia nervosa, the eating disorder, well, then that's a whole other ballgame. Psychological and psychiatric treatment become the priority. From a nursing perspective, it's about practical strategies. Offering small, frequent, high-calorie snacks throughout the day. Keeping a close eye on calorie intake. A registered dietitian can be a huge help here, tailoring a meal plan.
Makes sense.
And sometimes doctors might prescribe medications called appetite stimulants. Marinol and Megas are a couple of examples, but those are always used under careful medical supervision.
Got it. So moving on to something, unfortunately, most of us are pretty familiar with, nausea and vomiting.
Ah, yes, the dreaded duo.
You all know that awful feeling. But what's actually going on in our bodies when we experience this? And what are some of the usual suspects that trigger it?
It's more complex than you might think. Nausea and vomiting, they're actually protective reflexes, believe it or not. Your body's way of trying to expel something that might be harmful.
Okay, so it's trying to protect us in a way.
Exactly. And the triggers, oh man, the list is long. Medications are a big one. Tons of different meds can cause it. Infections, whether it's a virus or bacteria, can definitely lead to nausea and vomiting. Then you have things like blockages in the digestive tract, certain cancers, and of course, pregnancy. It's often one of the first signs.
Yeah, makes sense. So, aside from the obvious misery of feeling sick and throwing up, what else should we be watching for? Especially if it's happening a lot or lasting for a while?
Right, so beyond the obvious, dehydration is a big concern. You might notice a dry mouth, and the skin loses its elasticity. If you pinch the skin and it doesn't spring back quickly, that's what we call poor skin turgor, a sign of dehydration.
Okay.
And then there's the loss of appetite, feeling weak, maybe even unintended weight loss, and potentially some serious problems with electrolytes, those minerals like sodium and potassium that are crucial for your body to function properly.
And those can get out of whack from vomiting.
They absolutely can. You're losing fluids and essential minerals.
Got it.
And of course, if you're not eating properly because of the nausea and vomiting, you can develop nutritional deficiencies as well.
That's a lot to keep in mind. So how do these electrolyte imbalances show up in tests?
We look at the blood work. Specifically, we're checking the serum levels of electrolytes like sodium, chloride, potassium, and bicarbonate. If those are low, it tells us the body's balance is off because of those fluid and mineral losses.
Okay, that makes sense. So what's the typical game plan for managing someone who's having significant nausea and vomiting?
First things first, we need to tackle dehydration and those electrolyte imbalances. Usually that means IV fluids and giving back those lost electrolytes through the IV as well. Medications are a big part of it too.
Like what?
We use antiemetics. Those are drugs that fight nausea and vomiting. Zofran, Phenergan, Tygan, those are a few common ones. But the most important thing, really, is figuring out what's causing the problem in the first place.
Yeah, treat the root cause, right?
Exactly. Nursing care involves really paying attention to the details. How often is the nausea happening? How much are they vomiting? What seems to bring it on?
So lots of observation.
It's crucial. We also monitor hydration really carefully. Daily weight checks, blood pressure readings, keeping track of how much fluid they're taking in and how much they're putting out, and checking that skin turgor we talked about. Comfort is a big part of it too.
Right.
Having an emesis basin within easy reach, good oral hygiene helps with that awful taste that can linger. And trying to get rid of any strong smells in the room, those can make nausea worse. Some people find relief from alternative therapies like acupressure. Applying pressure to a specific point on the wrist can actually help.
Interesting. I've heard of that.
It can be surprisingly effective for some people. When it comes to what you eat, or rather what you can keep down, we usually start slowly. Small sips of cold water, ice chips, if they can handle it, maybe some ginger ale or room temperature broth.
Yeah, bland stuff.
Exactly. Bland and dry is the key. Crackers, plain toast, rice, bananas, Jell-O. Those are usually easier on the stomach when you're feeling queasy. It's generally a good idea to avoid mixing hot and cold foods and definitely steer clear of carbonated drinks.
Makes sense. What about electrolytes? How do you replace those?
Sports drinks like Gatorade can be helpful, but you have to be careful.
How so?
Well, if someone's really dehydrated and not producing much urine, that's a red flag. It could mean things are getting worse.
Yeah.
We need to be alerted to that right away.
Okay, so monitor the urine output.
Definitely. And then, as they start to feel better, we slowly advance the diet. Clear liquids, full liquids, and eventually small, frequent meals of those bland, non-spicy foods. It's all about listening to your body and taking it step by step.
Good advice. Okay, shifting gears now. Something a bit more serious. Cancer of the oral cavity. Sounds like some pretty clear risk factors to watch out for here.
Yeah, unfortunately there are, and they're pretty strongly linked to some lifestyle choices. Smoking, first and foremost.
That's no surprise.
And that includes smokeless tobacco, like chewing tobacco. It's not a safe alternative. Excessive alcohol consumption is another big one. And now we're seeing a significant number of cases linked to HPV, the human papillomavirus. About 70% of oral cancers are now connected to HPV.
Wow, I didn't realize it was that high.
It's a significant factor, and the risk is especially high when you combine tobacco and alcohol. It really emphasizes the importance of being aware of these connections.
Yeah, definitely food for thought. So, what's the prognosis like for someone diagnosed with oral cancer?
Well, the good news is, if it's caught early, the cure rate is actually pretty good.
That's encouraging.
It is. And that's why regular dental checkups are so important. Your dentist is often the first line of defense. They can spot those early signs.
Right.
And of course, it's important to pay attention to any changes in your mouth. If something seems off, Don't ignore it.
So what are some of those early signs, the things that should prompt someone to get checked out?
The first things you might notice are a lump or a sore, a lesion on your lips or anywhere inside your mouth. It could also be a red or white patch that just won't heal. It hangs around for more than a couple of weeks. Any sore that doesn't go away, any ulcer, any unusual growth, really, you want to get that looked at. The most common types of oral cancer are squamous cell carcinoma and those linked to HPV.
Right.
And this really highlights the importance of prevention. Quitting smoking, or better yet, never starting, cutting back on alcohol. And the HPV vaccine is something to consider as well. It can protect against some of the strains that are linked to these cancers.
Good advice. So what does treatment typically involve?
Usually it starts with surgery to remove the cancerous growth. And depending on the stage of the cancer and where it's located, that might be followed by radiation therapy.
Okay. And what about the immediate care after someone has oral surgery for cancer? What does that look like?
Right after surgery, the patient will be positioned lying flat with their head turned to the side.
Why is that?
It helps drain any fluids and prevents them from accidentally inhaling anything. As the anesthesia wears off, the head of the bed is raised. That helps with breathing and reduces swelling. It's crucial to have suction equipment, oxygen, and a tracheostomy set at the bedside, just in case there are any breathing problems.
You have to be prepared for anything.
Absolutely. And the patient won't be allowed to eat or drink anything until their swallowing reflex comes back. That's called being NPO.
Right. Makes sense.
When they do start eating again, it'll be very gradual. Small sips of liquid at first.
Baby steps.
Exactly. They'll also be given medication to prevent nausea and vomiting. Those are called antiemetics. Zofran, Tigan, promethazine, those are a few common ones.
Okay.
It's worth noting that promethazine can sometimes make people drowsy.
Oh, good to know.
In some cases, a nasogastric tube, an NG tube, might be put in to provide nutrition directly to the stomach. And patients are told not to use straws.
Why no straws?
The suction can interfere with healing. Throughout the recovery process, nutritional support is crucial, making sure they're getting enough calories and protein to heal. And psychological support is just as important. Dealing with a cancer diagnosis and treatment is a lot to handle.
It really is. You mentioned NG tubes a couple of times. Sounds like they're used for a variety of things in upper GI issues. What are the main reasons for inserting one?
They're pretty versatile, actually. One major reason is gastric decompression. Basically, removing gas and fluid that's built up in the stomach.
Okay.
That can relieve pressure, especially if there's a bowel obstruction. Or they might do it before some types of abdominal surgery to prep the area.
I see.
They can also be used to help treat some types of bowel obstructions directly. And if there's bleeding in the upper GI tract, an NG tube can be used to apply pressure and help control the bleeding.
Wow. So many different uses.
There's also gastric lavage. That's basically washing out the contents of the stomach. You might do that in a case of poisoning or overdose, for example.
That makes sense.
And then, of course, a very common use is to provide nutrition and medications when someone can't swallow or eat normally.
Right. So it's a way to bypass the mouth and esophagus.
Exactly.
What about other kinds of feeding tubes? Are there any besides the NG tube?
Yeah, there are a few different types. The nasogastric tube, that's the one that goes in through the nose.
Right.
There's also an orogastric tube, which goes in through the mouth. And then for longer-term feeding, they often use tubes that are surgically placed.
Okay.
One common type is a gastrostomy tube, often called a PEG tube or a G tube, that goes directly into the stomach through the abdominal wall.
So it's a more permanent solution.
It is. And there's also a jejunostomy tube, where the tube goes into the jejunum, part of the small intestine, again through the abdominal wall. Which type they use really depends on the person's individual needs and how long they'll need the feeding support.
Makes sense. How do they make sure those NG tubes are placed correctly? You don't want it ending up in the wrong place.
You're absolutely right. It's crucial to get it right. First, they do this thing called the NEX measurement. It stands for nose to ear to xiphoid process. That's the bony part at the bottom of your breastbone. That gives them an estimate of how far to insert the tube. But the gold standard for confirming placement is an X-ray. Once the X-ray shows the tip of the tube is in the stomach, they'll check the pH of the fluid that comes back up through the tube.
What's pH?
It's a measure of acidity. A pH of 5.5 or lower, that's usually a good sign that the tube is in the acidic environment of the stomach.
Interesting.
And finally, they mark the tube where it exits the nose, usually with tape or ink. That way, they can easily check to make sure the tube hasn't moved out of place.
So it's a multi-step process to ensure safety.
It really is.
The presentation mentioned the term NG tube to suction. What exactly does that mean?
So when an NG tube is connected to suction, it means there's a machine gently pulling out fluid and gas from the stomach.
Okay.
It could be continuous suction or it could be intermittent, meaning it cycles on and off. This is often used in cases of bowel obstruction to relieve pressure and prevent vomiting.
I see.
And they might also use it after certain abdominal surgeries to give the digestive system a rest and prevent fluid from building up.
Makes sense. There was also a question of the day about enteral feeding through an NG tube. The scenario was a nurse checks and finds 200 milliliters of residual volume before the next scheduled feeding. What should the nurse do in that situation?
That's a good question, and it highlights the importance of careful monitoring. In that scenario, the correct action is to hold the feeding.
Why is that?
Well, that 200 milliliters of residual volume, it tells us that the previous feeding hasn't fully emptied from the stomach yet. If you give more feeding on top of that, it could increase the risk of aspiration.
Aspiration, meaning...
The feeding going into the lungs, that's a serious complication.
Right.
And it can also cause discomfort and potentially lead to vomiting. The stomach needs time to empty properly.
So better safe than sorry.
Yeah.
Hold the feeding and reassess later.
Exactly. And if those high residual volumes keep happening, the doctor needs to be notified.
Got it. Okay, let's talk about esophageal disorders now, starting with a really common one, GERD, gastroesophageal reflux disease. So what's the deal with GERD? What's happening in the body when someone has this?
Basically, with GERD, the stuff in your stomach, the acid, the food, it flows back up into the esophagus. It's called reflux.
And why does that happen?
Because the barrier between the stomach and the esophagus isn't working properly.
Right.
There's this ring of muscle at the bottom of the esophagus called the lower esophageal sphincter, LES for short.
Okay.
It's also sometimes called the cardiac sphincter. It acts like a one-way valve. Food goes down into the stomach, no problem. But it's supposed to prevent things from coming back up.
Right.
With GERD, that LES is either weak or it relaxes when it shouldn't. And that's when you get that backflow, the reflux, which irritates the lining of the esophagus.
Okay, I get it. So what are the risk factors for developing GERD? What makes someone more likely to have it?
Quite a few things. Obesity is a big one.
Oh, so?
Well, extra weight in the abdominal area puts more pressure on the stomach, making it more likely for stuff to get pushed up into the esophagus. Pregnancy can have the same effect. And lifestyle choices matter too. Regular alcohol consumption and smoking, both of those weaken the LES muscle.
So those are things to watch out for.
Definitely. And then there's hiatal hernia. We'll talk more about that later.
Yeah.
But it can also contribute to GERD. And certain foods can trigger symptoms in some people. It's not the same for everyone, but it's something to be mindful of.
So what are the typical signs and symptoms? What would make someone think, maybe I have GERD?
Well, heartburn is probably the most common and well-known symptom.
A burning sensation in the chest, right?
That's it. We call it pyrosis, too. But there's also indigestion, dyspepsia. That's a more general feeling of discomfort in the upper abdomen.
Okay.
Some people with GERD also experience regurgitation, where stomach contents actually come back up into the mouth. And sometimes there's difficulty swallowing, which we call dysphagia, or pain when swallowing, odynophagia.
Wow, that's a mouthful, literally.
It is. And if that reflux keeps happening, it can lead to inflammation of the esophagus. That's esophagitis. And one of the biggest concerns with long-term GERD is that it can increase the risk of a condition called Barrett's esophagitis.
What was that?
In Barrett's esophagus, the lining of the esophagus starts to change. It actually becomes more like the lining of the intestine.
Yeah.
And that change, it's a known risk factor for esophageal cancer. So treating GERD and preventing those long-term complications is really important.
Definitely sounds like something you want to get under control. So how is GERD usually diagnosed?
Often they'll start with a barium swallow. That's an X-ray of your upper digestive tract. But you drink this chalky liquid that contains barium first. It helps highlight the organs on the X-ray.
Okay.
Another important tool is an upper endoscopy. That's where they insert a thin, flexible tube with a camera on the end down your esophagus. The doctor can see the lining directly, and they can take biopsies if needed.
Little tissue samples, right?
Exactly.
The presentation mentions specific pre- and post-procedure care for a barium swallow. What are the key things people need to know about that?
Yeah, before barium swallow, it's really important to be NPO. That means nothing to eat or drink for at least 8 hours before the test.
So you go in on an empty stomach?
Exactly. And afterwards, the doctor might prescribe a laxative.
To help get things moving.
Yes, it helps your body eliminate the barium. It's important to drink plenty of fluids too to help flush it out. And your stools might look chalky white for a few days.
Oh, that's interesting.
It's normal, but it can be startling if you don't know what to expect. It's also important to watch out for any abdominal pain or if you haven't had a bowel movement after a few days. It's rare, but that barium can sometimes cause a blockage if it doesn't pass through.
Okay, so if you notice those things, call the doctor.
Exactly. Better safe than sorry.
What about managing GERD? It sounds like there's a lot involved in that. What can people do, and what role does nursing care play?
Well, lifestyle changes are really the cornerstone of managing GER.
Like what?
They usually recommend avoiding foods and drinks that can either weaken that LES muscle or directly irritate the lining of the esophagus.
Okay.
So things like peppermint, chocolate, coffee, fried and fatty foods, carbonated drinks, alcoholic beverages, and of course smoking. All of those are no-nos.
So basically a lot of the good stuff.
Unfortunately, yeah. Eating a diet that's low in fat and high in fiber can also help. And timing matters too. You don't want to eat or drink anything for at least 2 hours before you lie down for bed.
Why is that?
When you're lying down, it's easier for those stomach contents to flow back up into the esophagus.
Gravity at work.
Exactly. Wearing tight-fitting clothing can make things worse too because it increases pressure in the abdomen. And a simple but effective tip, it uses gravity to your advantage. It makes it harder for the stomach contents to flow back up. Certain medications can also aggravate GERD.
Like what?
Things like anticholinergics, NSAIDs, and aspirin-containing drugs. If you're taking those, it's worth talking to your doctor about alternatives. And of course, following your doctor's instructions on any medications they prescribe for GERD is crucial.
Okay, what kind of medications are we talking about here?
They usually start with antacids, like Tums or Rolaids. Those provide quick relief by neutralizing the acid in your stomach.
But those are more for symptom relief, right?
Right, they don't actually heal any damage that's already been done.
Okay.
Then there are H2 receptor blockers like Pepcid or Zantac. Those work by reducing the amount of acid your stomach produces. They take a bit longer to kick in than antacids, but they provide longer relief, usually up to 12 hours.
I see.
And then there are proton pump inhibitors, PPIs for short, Prilosec, Nexium, Protonix. Those are a few common ones. They're the most powerful acid reducers. They block the pumps in the stomach lining that actually produce the acid. And the great thing about PPIs is that they can actually help heal damage to the esophagus over time.
So they address the underlying problem, not just the symptoms.
Exactly. And for some people, if lifestyle changes and medications aren't enough, they might need surgery.
What kind of surgery?
The most common procedure is called fundoplication.
What do they do in that?
They take the upper part of the stomach, called the fundus, and wrap it around the lower part of the esophagus. It basically reinforces that LES muscle and helps prevent reflux.
Oh, interesting.
There's also a less invasive procedure called stretta. They use electrodes to create little burns on the LES.
Burns.
Yeah, controlled burns, don't worry. As those burns heal, the tissue tightens up, strengthening the sphincter. And a newer option is the LINX device. It's this small ring made of magnetic titanium beads that they surgically implant around the esophagus.
Magnetic beads. That's fascinating.
It is. The magnetic attraction between the beads helps keep the LES closed, preventing reflux. But the ring expands when you swallow, so food can still pass through.
Oh, that's clever. So lots of options for managing GERD.
There really are. It's about finding what works best for each individual.
Okay, let's move on to esophageal diverticulum. That sounds a bit less common. What's that all about?
It is less common. Basically, an esophageal diverticulum is a little pouch or sac that forms in the wall of the esophagus.
Okay.
The most common type is called Zenker's diverticulum, and it usually forms in the upper part of the esophagus.
And what causes that to happen?
We think it's usually due to weakness in the muscles of the esophageal wall. It could be something you're born with, or it could develop over time from increased pressure during swallowing.
I see. So what are the signs that someone might have this?
One thing you might notice is persistent bad breath.
How come?
Food can get trapped in that pouch and start to decompose.
Oh, yuck.
Not pleasant. They might also have trouble swallowing, and sometimes they regurgitate undigested food that's been sitting in the pouch.
Okay.
That can actually lead to aspiration pneumonia if food particles get into the airway.
That sounds serious.
It can be. Other symptoms might include a chronic cough, unexplained weight loss if they're not able to eat enough because of the swallowing problems, and sometimes even neck pain or a feeling of fullness in the neck.
So how do doctors figure out if someone has this?
A barium swallow is usually the first step. Remember that chalky liquid I mentioned?
Right.
When they swallow that, it fills the esophagus and will also fill the diverticulum, making it show up on the x-ray. They can also do an esophagoscopy where they insert a thin, flexible tube with a camera into the esophagus.
To see it directly.
Exactly. But they have to be careful doing that to avoid poking a hole in the pouch. Sometimes they do an upper GI series too. That's a series of x-rays of the esophagus, stomach, and duodenum after you drink barium.
So lots of ways to visualize what's going on.
There are.
And how do they manage it? What's the treatment like?
It really depends on the size of the diverticulum and how bad the symptoms are.
Okay.
If it's mild, dietary changes might be enough. They might recommend eating a bland, soft diet, maybe even pureed foods or liquids, just to make swallowing easier.
So easy to swallow foods.
Exactly. But for more troublesome cases, they might need surgery to remove the pouch. That's called surgical excision.
Okay.
There are things people can do on their own as well. Eating a bland diet to minimize irritation, chewing food really, really well to make it easier to swallow, eating smaller, more frequent meals,
Good advice.
and drinking plenty of fluids after meals to help clear the esophagus.
Like a rinse cycle.
Exactly. But if the symptoms are severe, causing real problems with quality of life or leading to complications like aspiration, then surgery is usually the best option. They remove the diverticulum and repair the esophageal wall.
Got it. Okay, another condition we need to cover. Hiatal hernia. What is that exactly?
So a hiatal hernia happens when part of your stomach bulges up through an opening in your diaphragm.
The diaphragm, that's the muscle that helps us breathe.
That's the one. It also separates your chest cavity from your abdominal cavity. There's a natural opening in the diaphragm called the hiatus, and that's where the esophagus passes through to connect to the stomach.
Okay.
In a hiatal hernia, the stomach pushes up through that opening. It can happen because of a weakness in the diaphragm that you're born with, or it can happen because of muscle weakness that comes with age.
So it's common in older adults.
It is. It's
Yeah.
pretty common in people over 70. And anything that increases pressure in the abdomen can make it worse.
Like what?
Pregnancy, for one, fluid buildup in the abdomen, ascites, obesity, tumors, even heavy lifting.
Oh, wow. So a lot of things can contribute.
They can. And there are a couple of main types. An axial or sliding hiatal hernia, where the stomach and the junction between the esophagus and stomach kind of slide up and down through that hiatus.
Okay.
And then there's a paraesophageal hernia, where part of the stomach squeezes through the hiatus and sits next to the esophagus.
And are there complications that can arise from this?
A lot of people with hiatal hernias don't have any major problems, but there are potential complications.
Like what?
Well, you can get ulcers in the stomach lining where it's trapped, bleeding can happen, hemorrhage, regurgitation where stomach contents come back up into the esophagus, that can lead to aspiration.
Right.
And in more serious cases, you can have strangulation where the blood supply to the herniated part of the stomach gets cut off, or incarceration where the stomach gets trapped in the chest cavity.
Those sound pretty serious.
They are. Those can lead to things like tissue death, necrosis, peritonitis, which is inflammation of the lining of the abdomen, and even mediastinus, which is inflammation of the area around the heart and lungs.
So definitely something you don't want to mess around with. What are the symptoms like? How would someone know if they might have a hiatal hernia?
It can vary, but the most common symptoms are heartburn, belching, nausea, and pain or discomfort in the upper abdomen or chest.